Hello everyone, my name is Dr. Love and I am one of the Hematology Oncology Fellow. So this is our part 4 of this series. So let's start with a case. A 58-year-old woman admitted to the hospital. You checked her hemoglobin, it is 6.8 and you started a unit of pegged RBC. Approximately after 10 minutes of the transfusion, roughly she received 30 ml and she developed a shaking chills, temperature rise from 37 to 38.5 degrees centigrade. She developed a new back pain and flank pain. She's complaining some dyspnea, anxiety, and she says like there is a sense of impending doom. You checked her blood pressure, it is 82 over 48 millimeter of mercury, and the nurse checked the patient like Foley and she sees a dark red tinge urine. So what's your diagnosis? So this is your acute hemolytic transfusion reaction. So it is most often caused by ABO incompatibility red cell. It results mostly from patient misidentification or specimen labeling error. Very rare it is because of the laboratory failure. The classic symptoms are fever, chills and back pain. If someone have fever and back pain during transfusion, it is always acute hemolytic transfusion reaction until proven otherwise. So what are the other findings? People can get hypotensive, they can have hemoglobinuria, mean the hemoglobin in the urine, they can have an acute kidney injury because of the heme, and they can also undergo DIC. And what you will find on the laboratory? You will find elevated lactate dehydrogenase, elevated indirect bilirubin, low heptoglobin, hemoglobinuria, hemoglobinemia. If you remember from the last video, I say any transfusion reaction, the first thing is to stop the transfusion immediately. So you disconnect the blood product, you keep the IV line open so that you can start the normal saline. You always verify the patient identity, you recheck the labels, blood unit, patient identifiers, and you prevent a second mismatched transfusion. So third thing you do, you send some labs so that you can confirm the hemolysis. If you remember, I already spoke about those labs, but you also repeat the ABO and RH typing. You order an antibody screen, and if you find direct antiglobulin test positive, that means it suggests immune hemolysis. You support the patient with aggressive fluid so that you can prevent their acute kidney injury. Your target of urine output should be more than 0.5 to 1 ml per kg per hour. And if the patient become hemodynamically unstable, you can always start the patient on vasopressors and you always correct the electrolyte abnormalities. Remember, cells are the bags of potassium. So look for the hyperkalemia, and hyperkalemia can give you arrhythmia. And in severe cases, you need ICU monitoring, early nephrology consult, you need dialysis if required, and if someone develop DIC, you can always give them platelets if these are low, and FFP and cryoprecipitate. I hope you remember the indication. So back pain during transfusion is always acute hemolytic transfusion reaction until proven otherwise. In next video, we will talk about delayed hemolytic transfusion reaction.